I'd like to thank Binay for the invitation. This is my second time. Once I was dropping my daughter in college, so I couldn't come. So I'm glad to be here. And next year, I'm going to be taking the boards yet again. And don't get me started on the whole mock process. But you know, what's really interesting is that I feel bad about all my colleagues that don't treat lung cancer, because this is so much more complicated than anything else that I've been looking at. You know, perhaps leukemia. Anyway, so the only conflict of interest that I have is that recently I accepted editorial support to have a poster done by Pfizer, and that's because apparently the principal investigator or the first author of the poster was too lazy to put the poster together himself. So they paid like $10,000 for someone to do a poster, which made me wonder if I'm in the right profession. Maybe I should be doing posters, you know, all day. Anyway, I'm going to be talking about you know, molecular profiling in the context of target therapy as well as in the context of immunotherapy. So I'm going to present a couple cases. So this is the first one. This is someone that we saw as a second opinion in June of 2016, a female patient that had been diagnosed with a moderate differentiated squamous cell carcinoma, a T3N3 with supraclavicular disease, and she received chemoradiation therapy, which was completed in August of 2015. By December, she had recurrence in 3 different sites that had been radiated: the supraclavicular area, the primary, and the mediastinal. She started carbo and Abraxane initially with a response, but then had disease progression by May of 2016. And she's a lifetime non-smoker with an ECOG performance status of 0. So again, a patient that has a squamous cell carcinoma, moderate differentiated, received chemoradiation therapy, progressed shortly after, and has received in the palliative setting 1 line of platinum and paclitaxel-like. So obviously we don't have one of those press the button things, but and you don't have to raise your hand. I just want you to keep in your mind, what would you do in this case? Would you start a PD-1 or PD-L1 inhibitor? Would you start pemetrexed? Would you perform EGFR, ALK, and ROS1 testing in the context of broad molecular profiling? Or would you treat this patient with docetaxel and ramucirumab? So the patient pathology was reviewed at the University of Washington, which confirmed a squamous cell carcinoma. And we made our recommendation, but she decided to continue chemotherapy outside of our system and received 2 doses of pembrolizumab. And returned in August with a performance status of 2, not have responded at all to pembrolizumab. We then made the same recommendation that we had made before, and that was to enroll her in the MAP trial, which obviously, as you know, looks for molecular abnormalities in the context of squamous cell carcinoma, or used to. In fact, what I was doing, I was cheating so she could get broad molecular profiling for free. And we repeated CT that confirmed that she had evidence of disease progression. We performed a new biopsy of the supraclavicular lymph node, and molecular profile showed that she was not a candidate for the MAP trial because she had an EGFR mutation, an L858R. And she had a great response to erlotinib, and in April of this year, she went to France on a wine and culinary trip. So let's talk a little bit about target therapy. You know, Wally Ackerley here and Govindan on online, I guess, are both members of the NCCN guideline panel, and so am I. And sometimes, Wally, we go back to these slides and you go like, wow, this was just 2010. So this is the 2010 guidelines. And as you can see here, first of all, there is really no significant separation between non-small cell adenocarcinoma or squamous cell carcinoma at that time. And then we actually had to make a point there that, don't use pemetrexed if it's squamous cell carcinoma. And erlotinib for EGFR mutation patients to be considered as an option. Well, this is how it is today, a little bit more complicated. So as you can see there, we recommend EGFR, ALK, ROS1, and BRAF testing. And we recommend that testing should be made in the context of broad molecular profiling, as well as PD-L1 testing. So I would say that lung cancer is probably way up there in terms of the diseases that require molecular profiling for choice of first-line therapy. When we talk about EGFR mutation, the point of this talk is not to show you the data showing that first-line therapy in patients with mutation should be with an EGFR inhibitor. You all know that. The point of this talk is to talk about molecular profiling as a marker of which therapy should be given. And sometimes we talked about EGFR mutation as it's all the same thing. But I just put this slide in there to remind you that all the data that we have confidence of EGFR inhibitors being the appropriate first line for patients with a mutation comes from two mutations, L858R and exon 19 deletion. When you get into other mutations that are activating as well, we don't know for sure if they are superior to chemotherapy in the first-line setting. So here you have two of them that are probably the most common of the activating, not on those two. And as you can see, the response rate there is about half of what you would get. And the time to progression is also significantly shorter than you would get from the more common activating mutations. We've moved on from FISH to look at ALK. Places that have the Ventana machine are all now doing the Ventana antibody for ALK. And this is supposed to show, there you go. That's supposed to show that if you are ALK IHC negative, your tumor gets bigger. And if you are ALK IHC positive, your tumor gets smaller. And as you can see there, there is a very clear distinction between those two groups. This is an interesting story that I like to tell. So a while ago, we in the panel put this table of molecular predictors of response and therapies that were available at the time. And as you can see here, and as you know, in the NCCN guidelines, everything that doesn't have a category attached to it is a category 2A, meaning that 85% of the member institutions agree that this is an appropriate therapy if that molecular abnormality was present. And we got a lot of pushback. A lot of pushback from insurance companies saying that this was irresponsible, that some of these molecular markers there, the literature was based on case reports of just a few patients, and it was completely crazy to legitimize these treatments. And personally, when I feel strongly about something, I tend not to take criticism very well. So we responded to that criticism by adding the following statement at the guidelines. The NCCN non-small cell guidelines panel strongly advised broader molecular profiling with the goal of identifying rare driver mutations for which effective drugs may already be available, or to appropriately counsel patients regarding the availability of clinical trials. Broad molecular profiling is a key component of the improvement of care of patients with non-small cell lung cancer. Bang. So this is how the table looks like today. As you can see, lots of the items that had been criticized have now moved into the guidelines itself because we proved to be correct that they were indeed molecular targets that would pay off. And I suspect that before not too long, both the MET exon 14 splice mutation and RET will also get out of this table and into the guidelines. So this is just one example. This is a phase 2 trial of the dabrafenib plus trametinib in patients with a BRAF V600E mutation. And as you all know, that phase 2 trial showed a response rate of 62%, with the vast majority of patients having an improvement. I will skip anything that has to do with toxicity because I'm going to go back to that in a minute. I thought it was a little curious that 4 patients died during the study from fatal adverse events that were judged not to be related to treatment. In any case, this got approved by the FDA on June 22nd of this year. And this is how the guidelines of the NCCN look like now. We had a lot of discussion about first-line therapy versus second-line therapy. And I think that considering that this combination is associated with significant toxicity and impacting people's quality of life, we felt that probably both approaches would be reasonable. Either start with that or use as a second-line treatment. We also made a point that no one really knows what's the role of PD-1 inhibitors, even when there is a PD-L1 expression greater than 50% in these tumors that have a driver mutation. If you look at multiple trials, it seems that they have less benefit irrespective of their PD-L1 expression. So, for example, Keynote 024 that Govinda has already shown excluded patients with an ALK or EGFR mutation. So when you look at the first-line choice of chemo versus a PD-L1 inhibitor after progression on EGFR targeting, for example, we don't really know if these patients really will have more benefit from PD-L1 inhibition. I just want to give you a quick example of this drug that it's an NTRK inhibitor. And as I'm sure you know, the NTRK pathway is involved in nerve development. And I'm going to just move to this slide, which is a waterfall plot of different tumors and their tumor shrinkage associated with this new NTRK inhibitor. As you can see, this is effective in a number of different tumors as long as this mutation is present. And we have a trial open at the University of Washington if you happen to come across a patient with an NTRK fusion mutation, which is very rare. In non-small cell lung cancer, it's probably less than 1% of patients. But in some salivary gland tumors, the mammary variant of salivary gland tumor, that rate seems to be significantly higher. What about the predictors in immunotherapy? That's a much more complicated story. So that's the second case that I'm going to tell you about, and it's going to connect with a question that Binay asked earlier today. So this is a 55-year-old woman that presented outside of our system with stage 4 disease. She had a cervical lymph node, that's what determined her stage 4. And she was a smoker up to the diagnosis. And her pathology was a poorly differentiated non-small cell lung cancer. It was p63 positive, probably a squamous cell carcinoma. And she received a combination of concomitant docetaxel, cisplatin, and radiation therapy, plus 7T gray, which is obviously a pretty aggressive approach to someone that presented with stage 4 disease. She came to, interestingly, speaking of immunotherapy, she came to see us for a trial vaccine. That study has been published already. It was completely negative. But then she had evidence of disease progression while on the vaccine. She had a performance status of 1. And then she enrolled in the phase 1 clinical trial of an anti-PD-L1 antibody with the first dose in March 20th of 2012. That trial turned out to be one of the 2 publications in the New England Journal of Medicine, one of a PD-1 and another one of a PD-L1 antibody that changed everything we know about lung cancer. So this is her baseline scan. Remember, she started in March of 2012. As you can see, she has 2 sites of active disease that I show there. One is this necrotic hilar lymph node on the right side, and she also has a metastatic lesion to the left adrenal gland. And as you can see in follow-up, these lesions have pretty much disappeared. Obviously, hardly ever there is a complete response in the lymph node because that's a structure. It's not going to go away. But you can see that both return to a normal appearance. Well, as it turns out, this is April of 2015. That trial had a maximum of 18 cycles of therapy to be delivered, and patients had to stop. This patient remains on this response today. So she received 18 therapies with PD-L1 antibody that will never see the light of the day because BMS opted to go with their PD-1 antibody, which now turned out to be nivolumab. But it just shows that very strange things can happen with immunotherapy. She has been off treatment now for probably 4 years. No, I'm trying to pass with this. That's not going to work. And then she, in 2015, she completed the 150-mile Obliteride bike ride, which is a fundraise for the Fred Hutch, which actually is tomorrow. So who benefits from immunotherapy? We know that tumors that have no PD-L1 expression probably have a lower response rate. Not probably, they do. Smokers have a higher response rate. And patients with squamous cell carcinoma, as Govindan showed well, have a greater gain versus current therapy. In the absence of anything better to do with my life, I collected in 3 different studies with 3 different drugs the number of patients that were labeled as being negative for PD-L1. And I don't want to get into the different antibodies, the fact that the Atezo uses a counting of both the cancer cells as well as the immune cells. I'm not getting into that at all. I just want to tell you, let's just take on face value, those were the patients that were negative, according to whatever they call it. If you put all of it together, there were 171 negative tumors, and 15 of those responded, which is a response rate of 8.7%, which is incredibly similar to what you would expect from docetaxel in the second-line setting. So I think that this shows pretty well that excluding someone based on their negativity is probably not a good idea in the second-line setting. The other complicating is this fascinating paper that was published in JAMA Oncology, where they took a lymph node that was pretty much replaced by tumor, and then they performed PD-L1 testing with the same antibody in 2 different areas of that lymph node. And as you can see, one is strongly positive, and the other one is strongly negative. And that's the same tumor in the same patient, in the same spot. So I think I'm running out of time. Govinda already covered the 024 study. The only reason that I put that in there is because obviously that has a very well-defined biomarker, and that is the PD-L1 expression in more than 50% of the cells with the 22C3 antibody. That has been mentioned already earlier today as well, this idea that the burden of a mutation is a predictor of response, and that has been confirmed yet once more by this publication in the New England Journal of Medicine, showing that tumors with mismatch repair, colorectal cancer, had a much better response than tumors that don't have a mismatch repair, and the difference in mutation there is about 10-fold. And as you know, that's what led the FDA to approve pembrolizumab for patients that have tumors with mismatch repair, period. And that's just the graph. Again, this issue of mutation burden, as you all know, this trial that was published recently on New England Journal of Medicine showed that using a cutoff of 5%, there was no benefit of nivolumab over chemotherapy in the first-line setting, both for progression-free and overall survival. But using this, I think it's now proprietary test of high mutation burden, with, again, whatever definition they applied to that, which I think it's available only at Foundation Medicine, there was evidence that tumors with a high mutation burden did benefit from nivolumab over chemotherapy. So the biomarker problem for immunotherapy. Patients labeled as having negative tumors can still benefit, and you're going to have to take my word for it because I don't have a slide. But if you look at the appendix of the 057 trial published in the New England Journal of Medicine, that's the adenocarcinoma trial published on the New England Journal of Medicine of nivolumab versus docetaxel, the 10 patients, granted small number, but the 10 patients that were negative and responded to nivolumab had a quality of response that was exactly the same as the overall population in the group, with a median time to progression of 16 months. There is a clear heterogeneity of PD-L1 expression, as I showed in that slide. And there are multiple different antibodies, multiple ways of counting it. But we also need to keep in mind that even when it's super positive, the more than 50%, the response rate is still in the 40 to 50%. In fact, on Keynote-024 was 45%, 44.8, whatever it was, which is much lower than you would expect from a true biomarker like EGFR, ALK, and ROS1. This may or may not matter. I think that Govinda showed this well, so I'm not going to spend a lot of time talking about Keynote-021. But as you know, this was a randomized trial of chemotherapy plus minus pembrolizumab. The chemotherapy was carbo and pemetrexed, so obviously this is only for non-squamous tumors. The response rate was interesting. The response rate for patients overall was, I think, 55% response rate for patients treated with chemo plus immunotherapy. However, the response rate had a U-curve. It started at 56 if you are completely negative, then down to 38 if you were between 1 and 49%, and then jumped to 80% if it was above 50% of PD-L1 expression. Granted that 80% is based on only 20 patients. But as you can see here, I think that there is only one unfortunate patient that did not have some degree of tumor shrinkage when treated with the chemo plus immunotherapy. And this is the progression-free survival. And I'm showing a slide that you had not seen before, and that's the updated survival presented at ASCO this year, where there seems to start to appear a separation of the curves in favor of chemo plus pembrolizumab. And I will say that the updated, because I'm one of the authors of this study, I've seen the data that will be presented at ESMO this year, and that trend continues. So this is one possible strategy. if you have someone that has a non-squamous or a squamous cell with no smoking history, so non-squamous or squamous with no significant smoking history, if they have rapidly progressive disease, you probably want to do a focused EGFR testing, ALK, IHC, and PD-L1 by 22C3 antibody, and then decide what you want to do. If they don't have rapidly progressive disease and you feel that you have a little time, and your broad molecular profiling is available within 2 weeks, I think it's reasonable to do the straight broad molecular profiling plus PD-L1 antibody testing with 22C3. And so a molecular-directed therapy is more complex than in any solid tumor that I'm aware of. Approximately 50% of patients with advanced disease will now not receive chemotherapy as their first line. And these 50% are the patients with EGFR, ALK, ROS1, and the 30% that will be PD-L1 greater than 50%. So if you add all of them up, you get to 50%. We know the outcomes for patients with exon 19 deletion and L858R, but more uncommon activating mutations is not so certain what their outcome is versus chemotherapy. They definitely should be treated at one point. If they should or should not receive first-line therapy, I think it depends how much of a window of opportunity you think you have. ALK IHC has now, where available, replaced FISH, which is obviously much faster and cheaper. And the only antibody that should be used to direct therapy with PD-L1 or PD-1 drug, in this case PD-1, obviously, is the 22C3 for pembrolizumab. All the other drugs do not require testing. And that's all I have to say.
Thank you, Dr. Martins, for that. The treatment for lung cancer continues to get more and more complicated, and that's obviously a good thing for patients.